Can you restart? Okay, good morning, students. Today's topic of discussion would be RH isoimmunization in pregnancy. Vignesh, slide more there. So going to the little into the history of the RS disease, 1940s, Landsteiner was the person who discovered the RH factor. 1950s, Lilly found out the procedure of amniocentesis. In the 1960s, intraperitoneal transfusion was also invented by Lilly. 1970s, we had the antepartum prophylaxis, which was again invented by J.M. Bowman. 1980s, fetal blood sampling was done, and in 1990s, the Doppler of the MCA, that is the middle cerebral artery, was invented by Marie. This is a little into the history of the RS disease and its various events during the process. Now we go to the RH in particular. There are two major classification systems for grouping blood. One is the ABO classification, and two, you have the RH or the Rhesus classification. So coming to the Rhesus blood group system, that is the RH factor, what we say, is a red blood cell surface antigen that was named after the monkeys in which it was first discovered. And this RH factor is inherited as a Mendelian dominance. The genotype is determined by the inheritance of three pairs of closely linked allelic genes, and these genes are situated on the short arm of chromosome 1 named as the capital D/D, capital C, small c, capital E, and small e. This is again by the Fisher-Race theory. The gene small d is an amorphic and has no antigenic expression. So there are only 5 effective antigen, that is the capital D, capital C, small a, capital A, and the small e, which is taken into consideration for discussion of the blood group system. D, as we said, the capital D is the most immunogenic in the RS system. And there are also other varieties other than the capital D. There is a rare type of RH negative called RH null who lack all known RH antigens. So the D antigen has no natural antibody, while the C and the E have corresponding natural antibodies, though weak, and they are found often infrequently. So now we have understood there is only capital D, capital E, small e, capital C, small e. So an individual may be homozygous or heterozygous for each of these, inheriting one trait from each parent. So in general population, 60% of the RH negative men are heterozygous and 40% of them are homozygous. So the overall RH negative pregnancy having a chance of an RH positive fetus is 60% irrespective of the father's genotype. I think it is very clear. 60% of them are RH heterozygous positive and 40% of the men are homozygous positive. So if the mother is RH negative, the chances of having an RH positive is 60%, irrespective whether the father is homo or heterozygous. So how does this inheritance come? The fetus in general receives its genetic components from the parents, and thus the blood grouping of the fetus may differ from that of the mother also. The RS factor is an antibody directed against an erythrocyte surface antigen of the Rhesus blood group system. And this shows a high degree of pleomorphism. 5 major antigens may be recognized. As I told you, it's a capital D, capital C, capital E, small e. No O antigen has been identified, as I mentioned earlier also. So this is a flow chart to describe how the rhesus factor is inherited. So the mother here is Rh negative. The father is homozygous positive, which is to the right, and on to the left is father is heterozygous Rh positive. So what are the chances? The second group, D, small d, is the genotype of the father. So what will be the blood group inheritance of the fetus? If the father is homozygous positive, then there is a 50% chance that the baby will be Rh positive. So you have one Rh positive 50%, the other is Rh negative 50%. Sorry, if the father is homozygous positive, there is a 100% chance, that means the baby will definitely be Rh positive. If the father is heterozygous, there is a 50% chance the baby is Rh negative. So 50% will be Rh positive and the other 50% will be Rh negative. So the chances of isoimmunization, if the father is homozygous positive, is 100%. If the father is heterozygous, there is a 50% chance. So to explain it, so if the mother is Rh negative, fetus is Rh positive, the probability of Rh positive fetus will depend on whether the father is homozygous or heterozygous, as I already showed you in the flow chart. A person who carries capital D on both sets is homozygous, and if there is only one capital D, then he is heterozygous. So if the father is homozygous, all the children will be Rh positive. Is that clear? If the father is heterozygous, half of the offsprings will be Rh positive and the other half will be Rh negative. So this is very, very important why we should know the genotype of the father in a case of Rh negative women so that we can predict which are the cases which are going to be affected. So what do you understand by the terminology isoimmunization? It is a production of immune antibodies in an individual in response to an antigen derived from another individual of the same species, provided the first one lacks antigen. So isoimmunization is an production of an immune antibody in response to an antigenic stimulus. So for this Rh isoimmunization to occur, there are certain conditions which must be fulfilled. One, the fetus must have the Rh positive RBCs and the mother must possess the Rh negative RBCs. A sufficient number of fetal RBCs must gain access to the maternal circulation. The mother must have the immunogenic capacity to produce the antibody directed against the D antigen, which she may not have as she is Rh negative. So she may be immunized by the blood transfusion before pregnancy. So the three important conditions are the fetus must have the Rh positive RBCs and this must enter into the maternal circulation, and the mother sufficient number of fetal RBCs must gain entry, and three, the mother must have the immunogenic capacity to produce the antibodies against this crossed over the antigen from the fetus. Sometimes she may also be immunized by the transfusion of Rh positive cells before pregnancy. So coming to the incidence is very high in the developed countries like in the European or in the American countries, accounting for about 15 to 17%. And in India, the incidence is about 5 to 10%. In South India, it's about 5%, it's about 10% in North India. It is very insignificant in China, occurring in about 1% of the cases, and it is almost nil in Japan. The incidence is almost nil in Japan. So coming to what is the pathogenesis of RH isoimmunization? The feto-maternal hemorrhage results in the passage of RBCs into the maternal circulation, that is from the fetus, and the maternal response is enclosed. So this feto-maternal hemorrhage can occur at any time during the pregnancy. The incidence of RH isoimmunization in the first trimester is about 6.7%. In the second trimester, it is about 15.9%. In the third trimester, the incidence is 28.9%, or it may occur during delivery and the incidence is as high as 15 to 50%. So the maximum incidence of feto-maternal hemorrhage occurs during delivery. So for RH isoimmunization to occur, as I already explained, the fetal RBCs must pass from the fetus to the maternal side, and the mother should produce an antigenic response to these antigens. So the various RH antibodies which are involved in RH isoimmunization are saline antibodies and the albumin antibodies. The saline antibody is the immunoglobulin M. It is the first to form in response to a first antigenic stimulus. It is a primary immune response. It has got a large molecule with a molecular weight of about 50,000 daltons. So because of its heavy molecular weight, it cannot cross the placenta and it does not produce fetal red cell hemolysis. And this is usually present from 6 weeks up to 12 months. The second RH antibody would be the albumin antibodies, which is immunoglobulin G. It produces a secondary immune response. It is a smaller molecule. The molecular weight is very less. Hence, it does not cross the placental barrier and the fetus does not get affected. Okay. So the first immunogenic response will be an IgM, which is a larger molecule with a molecular weight of 50,000 daltons. Hence, it does not cross the placenta, and hence the first pregnancy, that is primigravida, most often remains unaffected, and because this stays in the blood from 6 weeks to 12 months. Whereas the second immunogenic response is produced by the albumin bodies, which has got a smaller molecular weight, easily crosses the placenta, and hence the baby gets affected. So coming to the pathogenesis of RH isoimmunization, in a flow chart, RH negative mother with an RH positive father who could be homo or heterozygous. The fetus, if it is RH negative fetus, so if the father is heterozygous, there is a 50% chance, so there is no problem at all. The problem comes only if the fetus is RH positive. So these RH positive RBCs from the fetus enter into the maternal circulation. If the mother is non-sensitized, there is a primary immunogenic response, and so the baby does not get affected. So the first baby usually escapes, but the mother gets sensitized. If the Rh positive RBCs enter into the maternal circulation in a previously sensitized woman, there is a secondary immune response. So the IgG antibodies freely cross across the placenta, affect the fetus, resulting in hemolysis. So this is how the immunogenic response occurs in a primigravida or in a multigravida. As I told you earlier, the primigravida, the first pregnancy, usually escapes. Only caveat is that she must not have received a Rh positive blood transfusion earlier. So what are all the factors which predispose to the feto-maternal leak? In the first trimester, it could be a spontaneous or an induced miscarriage, a chorionic villus biopsy, or a sampling which is done in the first trimester, amniocentesis, second trimester, external cephalic version, where you used to convert an podalic presentation into a cephalic, that is a breech into a vertex presentation, manual removal of placenta, any type of abdominal trauma which could be blunt, placenta previa, accidental hemorrhage, which constitutes antepartum hemorrhage, intrauterine death of the fetus, and cesarean section. So these are all the various factors which predispose to feto-maternal hemorrhage and RH isoimmunization. So even though there is an immunogenic response, all mothers do not produce antibodies. So even though the transplacental fetoplacental hemorrhage is very common, RH isoimmunization does not occur in every woman. So RH isoimmunization depends on various factors. The most important 4 factors are: one is the volume of feto-maternal hemorrhage. That means at least 0.1 ml of the RBCs have to be crossed from the fetus to the maternal side, and this is considered as a critical sensitizing volume. So this is a minimal volume for feto-maternal hemorrhage to occur. Number 2 is the maternal responsiveness. So even though the feto-maternal hemorrhage has occurred, all mothers do not get affected. Only 1/3 are non-responders. And 3, this depends on the strength of the antigenic stimulus and also the ABO compatibility. The ABO compatibility usually protects against the RH isoimmunization. So it is very clear, even though there is feto-maternal hemorrhage, it depends on the volume of the feto-maternal hemorrhage, the maternal response, not all, only 1/3, and the strength of the antigenic stimulus, ABO compatibility, usually protects the RH isoimmunization. So ABO incompatibility protects against RH isoimmunization. Primary response is mainly IgM, which cannot cross the placenta. So first pregnancy is usually unaffected. Subsequent response is by the IgG antigen, which causes the placenta and produces fetal disease. So this is about how the inheritance and the immunogenic response occurs. Now, how do you screen this Rh negative women? So all pregnant women, as soon as she comes for an antenatal visit, should undergo ABO and Rh blood testing. If the lady is Rh positive, then there is no need. She goes for a routine antenatal care and she's a low risk pregnancy. If the pregnant woman is Rh negative, then the husband's blood group is to be done. If the husband is Rh negative, then no further investigation is required and this pregnancy is managed as a normal one and you do not require any other additional care and you put it into the general antenatal care. So is that clear? So all pregnant women should have ABO and Rh blood group testing. If the mother is Rh positive, there's no problem. If the mother is Rh negative, then you test the blood group of the husband. If the husband's blood group is Rh negative, no further investigation is required and you put it under low category, low risk category under routine antenatal care. If the husband is Rh positive, then there are chances of Rh immunization, and so there is further investigation in the mother has to be undertaken. And this investigation would be your ICT or the indirect Coombs test. This indirect Coombs test should be done at the 28 weeks of pregnancy or earlier if there is history of Rh isoimmunization in the previous pregnancy, usually 10 weeks before the antecedent event. So what are all the manifestations if the fetus is Rh? Isoimmunization has already occurred and the mother is Rh negative and the fetus is Rh positive. The various manifestations of hemolytic disease would be the maternal and the fetal. The maternal problems are there is increased incidence of preeclampsia, polyhydramnias, large-sized babies or macrosomias more than 4 kgs, increased incidence of postpartum hemorrhage due to large placenta and coagulopathy. There is something called a mirror syndrome. These are caused by vascular changes in the placenta. The mother develops preeclampsia and edema, which is very similar to the fetus. In the fetus, it produces a Buddha position, and that is the reflection in the mother as a mirror syndrome. The generalized edema influences the fetal position, which is referred to as Buddha position with a halo around the neck. And this halo is because of the edematous scalp. The fetal complications would be immune hydrops, that is the presence of abnormal fluids in 2 or more sites such as the thorax, abdomen or the skin. Heart failure most often occurs from prolonged anemia, capillary leakage caused by hypoxia with severe anemia. Portal and umbilical venous hypertension occurs from hepatic parenchymal disruption by extramedullary hematopoiesis. Lower osmotic pressure also produces hemoproteinemia due to endothelial dysfunction. So these are the various maternal and fetal complications which occur in hemolytic disease. The other fetal complication would be, one is the hydrops, the second is icterus gravis neonatorum, where the baby is born alive without any evidence of jaundice, but it soon develops it within 24 hours after birth. Number 3, the fetal complication would be congenital anemia of the newborn. This is the mildest form of the disease. The anemia develops slowly, the jaundice is not evident. The newborn may be pale with a hemoglobin level of less than 10 gram per deciliter with enlarged liver as well as spleen. So the 3 important fetal conditions in the hemolytic disease of the newborn, 1 is the hydrops fetalis, 2 icterus gravis neonatorum, and 3 is the congenital anemia of the newborn. So what is hydrops fetalis? So let us go into the detail of what is hydrops fetalis. There is an excessive destruction of the fetal RBCs which leads to severe anemia, tissue anoxemia, metabolic acidosis with an adverse effect on the fetal heart, brain and placenta. So there is hyperplasia of the placenta occurs. This is an effort to increase the transfer of oxygen. There is damage to the liver, leads to hyperproteinemia. So this in turn causes generalized edema, ascites and hydrothorax. Fetal death may also occur. Either there may be a stillbirth or macerated even if it is born alive and dies soon after. So these are the diagnostic features, how it looks like at birth and ultrasound. Ultrasound, there is edema of the skin, scalp, pleural and pericardial effusion with an echogenic bubble. X-ray of the abdomen shows a Buddha position of the fetus with a halo around the head. At birth, it looks pale, edematous, with enlarged abdomen due to ascites, and there is hepatosplenomegaly. The placenta is very large, pale, and edematous. So the clinical manifestation in the flow chart I've explained here, the hemolysis which occurs in the utero can produce anemia with increased bilirubin, that is hyperbilirubinemia. This anemia can produce increased hepatic erythropoiesis dysfunction, resulting in portal and umbilical vein and hypertension in the heart. It can also produce, in the fetus after birth, it can produce jaundice, kernicterus, hepatic failure, either resulting in intrauterine fetal death or death after birth and producing what is known as erythroblastosis fetalis. Okay, so this is the flow chart to explain the clinical manifestation in utero as well as after birth. So antepartum prophylaxis, as I already told you, these potential sensitizing events, all this which I've told earlier, that is spontaneous miscarriage, therapeutic termination of pregnancy, ectopic molar pregnancy, invasive prenatal test like cardiocentesis, CVS, amniocentesis, intrauterine procedures like embryo reduction, APH, external cephalic version, abdominal trauma, IUD stillbirth, instrumental or cesarean section, manual removal of placenta, and after transfusion of Rh positive cells, all require antepartum prophylaxis. So how do you give and how much you give, we will discuss. So trimester wise, you decide the antenatal prophylaxis. If the event occurs in the first trimester, that is less than 12 weeks, you give 250 international units or 50 micrograms. So the Americans use the international units, the British use micrograms, and I think in India we use micrograms. Whichever way, you should know the correct dosage. If the immunization occurs between, if the event has occurred between 12 to 20 weeks, then you have to give 250 international units or again 50 micrograms. That is the early second trimester. If it is more than 20 weeks, the anti-D should be 500 international units or 100 microgram, that is in the late second trimester. Third trimester, between 28 to 34 weeks, you have to give 1,500 international units or 300 micrograms for routine anti-D prophylaxis, and it could be given as a single or a double dose. The ACOG recommends that a single dose should be given, whereas the British prescribe double dose. The single dose is at 28 weeks, the double dose one is at 28 weeks, other is at 34 weeks. In India, because the cost of the anti-D is very high, we prefer to give a single dose of anti-D at 28 weeks of pregnancy. So now the management depends on whether the woman is unsensitized or she is already sensitized. So now we take up the management of unsensitized Rh negative women. So you have done an ICT, all women are Rh negative with Rh positive partum should have serum antibody testing. I already told you, if the ICT is negative, then it indicates that the woman is not immunized. If the ICT is positive, then it indicates that the woman is already immunized. So you have to make it clear, if the ICT is negative, then the woman is not immunized. If the ICT turns out to be positive, ICT we mean indirect Coombs test. If it is positive, this indicates that she is already immunized. Why do we say this is the treatment is different in a non-immunized and a immunized mother. So in a non-immunized mother, ICT will be repeated at 28 weeks and again at 34 weeks in a primary gravida. If at 28 weeks the mother is negative, you give 300 microgram of anti-D injection. In a multigravida, you repeat the ICT at monthly intervals after 28 weeks. If she is persistently negative, you check the blood group of the fetus after delivery, and if necessary, you can give an postpartum prophylaxis if the baby is Rh positive, but never allow her to go beyond term. And what are the precautions you take at the time of delivery? You have to do an early cord clamping because you want to limit the number of bed cells entering into the fetal circulation. And you collect the blood, and this blood which is collected from the cord, you send it to the lab for hemoglobin, for direct Coombs test, for serum bilirubin, and also for the hemoglobin estimation as well as blood group estimation. So how about, this is what I told you about the antenatal prophylaxis. It could be a single or a double dose, and it is given in all women where the ICT is negative. So coming to postpartum anti-D prophylaxis. So when do you give? If the baby is Rh negative, there is no need for postpartum prophylaxis of anti-D. Only if the baby is Rh positive, Anti-D immunoglobulin must be given within 72 hours, ideally within 48 hours, but you can give up to 72 hours. That is, the dosage is 300 micrograms. So, you have to find out this 300 micrograms covers 4 ml of feto-maternal bleed. Okay. So, if the feto-maternal bleed is more, it can occur in some instances. You have to find out what is the amount of. So, the different tests out the feto-maternal bleed are the Kleher-Betke test, the Rosette test, or the latest is the flow cytometer. So, what is this Kleher-Betke test? This test is performed on the maternal blood to assess the amount of feto-maternal bleed. Keeping in mind 100 microgram of anti-D will neutralize 4 ml of feto-maternal bleed. So apart from delivery, as I told you, there are other indications for antenatal prophylaxis. I've already told you the list of antenatal prophylaxis. The Rosette test indicates that the fetal D positive cells are present. Flow cytometry is the best. It detects the Rh positive cells, making it particularly helpful in patients with a high hemoglobin, fetal hemoglobin levels. So anti-D prophylaxis is a must. And in all other conditions of feto-maternal bleed, in addition to antenatal prophylaxis, mind it, whatever the event has occurred antenatally, you have given a prophylaxis. In addition, you have to give an antenatal anti-D prophylaxis as well as postpartum prophylaxis if the baby is Rh positive. Administration, how do you give? Anti-D is given 300 micrograms, is given deep IM into the deltoid muscle as an IM injection and not into the gluteal region, because it only reaches the subcutaneous tissue because of the fat, and absorption may be delayed, and hence it must be administered to the deltoid muscle. The dosage is a single dosage of 300 microgram will suppress the immune response of 15 ml of fetal Rh positive RBCs, approximating to 30 ml of the whole blood. So if this feto-maternal hemorrhage is in excess of this, then you have to do all this Kleher-Betke test, Rosette test, or the flow cytometry to estimate the exact amount of feto-maternal hemorrhage, and also to give an additional dose of anti-D if required. Then coming to what is the role of antenatal corticosteroids. Betamethasone 12 milligram should be given as an initial dose, and a second dose should be repeated after 12 hours to increase the lung maturity in case of early expected delivery, or in cases where preterm delivery is expected within the next 7 days. You have to give betamethasone or dexamethasone, but we normally prefer betamethasone. So 2 doses, 12 milligram, which should be repeated after 12 hours. Then how do you time the delivery? The timing of delivery will depend upon the severity of the disease and also the neonatal facilities which are available. In severe disease, the risk of invasive procedure should be balanced against that of the early delivery. In mild cases, you can continue pregnancy 38 weeks, which is the ideal time for delivery. So the management of non-immunized mother, father's Rh factor, father is Rh negative, there's no further testing. Father is Rh positive, you do the antibody screening of the mother at 28 weeks, that is the indirect Coombs test, and repeat every 4 weeks. If she is negative, anti-D prophylaxis at 28 weeks, single or double dose, and deliver the baby at 38 weeks. Precautions should be taken to prevent the possibility of increased chance of feto-maternal hemorrhage. That is, how do you take, what are all the things which you have to keep in mind during labor? As I told you, withhold prophylactic ergometrin, early cord clamping, avoid manual removal of placenta, and 15 to 20 centimeters of the cord should be left intact in case you have to do a transfusion after delivery. And during cesarean section, minimize or avoid the blood spillage into the peritoneal cavity. So you pack properly, wait for spontaneous separation of the placenta, avoid manual removal, and avoid avulsions of the cord. So all these precautions should be taken during delivery as well as during cesarean section, and these will reduce the amount of feto-maternal hemorrhage. So at birth, what do? As I already told you, early cord clamping, collect the cord blood and do the test in the mother as well as fetus. The cord blood sample, you have to do the direct Coombs test, blood grouping, RH typing, check for the bilirubin level, the hemoglobin, hematocrit, and if needed, you can also do a reticulocyte count. The maternal blood sample also should be taken and you check for indirect Coombs test, wait for about 30 to 45 minutes and then you do the collect the blood, and the fetal red blood cells in the maternal circulation can be estimated. So this is what you do at birth, that is the maternal as well as the fetal investigations. So if the fetal blood group is Rh positive, as we already told you, no antibodies are detected. Full dose of anti-D should be given 72 hours after delivery, and don't give anti-D if the fetus is Rh negative. So this is till now whatever I told you is about the management of the non-immunized mother. That means where the ICT was negative. Now coming to the management of the immunized mother. So whenever the ICT comes positive, you should refer the patient to a tertiary care hospital where all facilities for neonatal blood, that is in utero transfusion and invasive procedures are available. Okay, so if what is immunized mother, I again repeat, if the ICT is positive, it should be, then it indicates that the mother is immunized. So if the ICT is positive, you repeat the test in dilution. A titer of 1 in 16 is an indication for amniocentesis to detect the bilirubin. And if the titer is 1 in 16, it may be repeated 2 weekly. So if the ICT is positive, then the fetal blood group determination is very, very important because you can predict whether the fetus is going to be Rh negative or positive. For this, you have to check the genotype of the father. So if father is heterozygous, the fetus 100% will be Rh negative. So assessment of the blood group will help. And so also, you can also, other than the genotype of the father, you can do the chorionic villus sampling, amniocentesis, and fetal DNA testing to determine the fetal blood group. So if the ICT is positive in 1 in 16, you're supposed to do the amniocentesis and amniotic fluid bilirubin evaluation. The amniocentesis is done and the bilirubin is plotted. And this is plotted in the Lilly's chart, which has got 3 zones, usually performed at 28 weeks. Zone 1, if the serum bilirubin is usually charted with an optical density at 450 microns. If it falls in zone 1, the fetus is unaffected or is only mild disease. So in such cases, you continue pregnancy up to 38 weeks. If it falls in zone 2, that means there is fetal anemia. So you have to do a preterm delivery after 34 weeks, or you plan an intrauterine transfusion. Zone 3 indicates that there is occurrence of severe anemia. The hemoglobin is less than 8 grams and it definitely needs an intrauterine transfusion. So if the ICT is positive, more than 1 in 16, then amniocentesis is indicated and the serum bilirubin is plotted in a chart known as Lilly-Jones curve, and depending on which zone it falls, you decide the management. So fetal blood sampling and intravascular transfusion is the best method to assess and treat fetal anemia, and it should be done in a specialized center. It is not tracked, it is treat, and there is a little spelling mistake, please correct it. The fetal blood sampling is done from the umbilical cord at the placental site. And ultrasound assessment again is very, very important because accurate dating in the first trimester is very important, followed by the fetal growth assessment and also to identify whether the hydrops or the fetal ascites has set in. So what are the ultrasound features? This ultrasound is very, very important other than the first trimester dating scan in the first trimester, 2, the growth scan later, 2, anomaly scan, and 3, the growth scan in the third trimester. It is also used to detect the progress of the disease, that is, whether it has progressed from mild to severe. So the findings include fetal hepatosplenomegaly, fetal ascites, pericardial pleural effusions, fetal cardiomegaly, the increase in the portal venous diameter flow velocity, fetal scalp and skin edema, these occur very late, placental hypertrophy, that is large placenta, uh, either it could be an disturbance like poly or oligoamnias. So the ultrasound, it indicates the severity of the disease. So for the management purpose in an already immunized women, MCA PCV is very, very important. What is MCA? That is a middle cerebral artery Doppler. You measure the peak systolic value. MCA is middle cerebral artery. That is a Doppler, one of the Dopplers. PSV is the peak systolic velocity. MCA PCV is a highly sensitive, non-invasive method for determining the degree of anemia. The sensitivity of this Doppler is about 100%. MCA PCV greater than 1.5 mom, that is multiples of the median. Mom is multiples of the median. For the gestational age, it is indicative of moderate to severe anemia. 70% reduction in amniocentesis if used. So MCA-PCV is a highly sensitive test to be done in cases of already immunized women, and depending on the peak systolic velocity, if it is greater than 1.5 moms, it is indicative of moderate or severe anemia, and this is when you decide when to deliver. So the indications for doing an MCA-PCV are the antibody levels should be more than 1 in 28 or 15 international units, or there is a history of a previous fetal or a neonatal death, a fetal transfusion, or there is a history of a birth of a severely affected baby. So you have to do is at least 10 weeks prior to the antecedent event. The demerit is the accuracy diminishes after 35 weeks and after multiple transfusion, and you require a trained radiologist, that is the expertise, to give you a correct MCA PSV. The MCA of the cerebral hemisphere, that is how do you measure the MCA? Just few lines. MCA of the cerebral hemisphere closer to the ultrasound transducer is interrogated. That is, you take it from its origin from the internal carotid artery, but without including any of the internal carotid artery. And taking care, the angle of insonation should be as close to 0 as possible. The typical waveforms are obtained in peak systolic velocity. At least 3 of them should be measured and take the average of it. And threshold for the diagnosis of fetal anemia is equal to or more than 1.5 multiples of the medians or moms for the gestational age. So MCA PSV, that is a peak systolic velocity, middle cerebral artery Doppler, if it is less than 1.5 moms for the gestational age, you repeat the Doppler weekly, and if the results are persistently below 1.5 moms for the gestational age, you continue the pregnancy and deliver at 35 weeks. If the MCA PSV is more than 1.5 moms for the gestational age, if the gestation is less than 37 weeks, you have to give steroids for the lung maturity. If it is less than 34 weeks, of course, you do a chordosynthesis. And in the chordosynthesis, if the fetal hematocrit is less than 30%, plan for intravascular transfusion. If the fetal hematocrit is more than 30%, you do a weekly chordosynthesis. Weekly chordosynthesis. Okay. And if the gestational age is more than 35 weeks, you deliver the fetus. You may have to repeat chordosynthesis also. And in such cases, you deliver after 35 weeks or 2 weeks after the transfusion. So, okay. So, MCA PSV is very, very important for the management of delivery in an already immunized women. If it is less than 1.5 moms for the gestational age, you keep repeating the Doppler every week until it is less than 5 and you consider delivery at 35 weeks. If the MCA PSV is more than 1.5 moms for the gestational age, if it is more than 35 weeks, you deliver. If it is less than 35, consider steroids. If it is less than 34 weeks gestation, as I already told you, betamethasone or dexamethasone can be given. Plan for chordosynthesis. And in the chordosynthesis, if the fetal hematocrit is less than 30%, you consider intravascular transfusion and repeat the chordosynthesis after 2 weeks, or you can do a weekly chordosynthesis and deliver after 35 weeks or 2 weeks after the transfusion. So this is a flow chart. Immunized pregnancy, ICT positive, repeat what is a critical value, that is 1 in 16, not reached, repeat every 4 weeks, terminate 37. The critical value is reached, that is 1 in 16 and above. If the fetus is more than 34 weeks, you terminate, or if it is less than 34 weeks, as I told you, do the MCA PSV or amniocentesis, then do a chordosynthesis, plan for intravascular transfusion. And if it is the hematocrit is less than 30%, you consider intrauterine transfusion. So this is regarding how you deliver a immunized women. Coming to the neonatal management, cord blood is taken again for hemoglobin, bilirubin, and the direct Coombs test. If the baby is anemic, immediate exchange transfusion may be necessary with O group Rhd negative red cells. In case of repeated pregnancy loss due to hemolytic disease, what do? You plan for in vitro fertilization in the future. You can also think of embryo biopsy and transfer of only Rh negative embryo. That is an option if the father is heterozygous. Donor insemination from an Rh negative donor is also a positive result. These are in cases of high-risk pregnancy where there is multiple or a repeated pregnancy loss, IVF, embryo biopsy and transfer of an Rh negative embryo or a donor insemination from an Rh negative donor should be thought of as a possibility in order to get a successful pregnancy. So I thank you for a patient listening. I hope you have understood what is Rh isoimmunization and the management in a non-immunized and in an immunized manner. Thank you.